Assalamu alaikum and good evening all of you. Before starting anything, I would like to share a famous spiritual quote which I always use to amplify my abilities. It goes like Imam Ali Raza quote from his father Imam Musa Qasim. He quote from his father Imam Jafar Sadiq. He quote from his father Imam Muhammad Baqir. He quote from his father Imam Zainul Abidin. He quote from his father Imam Hussain. He quote from his father Maula Ali. He quote from the Holy Prophet Muhammad sallallahu alaihi wasallam. And he said, what faith is? Faith is knowing from your heart, expressing it through your tongue, and performing it with your organs. So whatever you do in life, faith is the basic necessity for everything. Now proceeding with the class 1C, this class is the most potent sodium channel blocker among all the three subclasses. Class 1A was moderately sodium channel blocker, the class 1B was limited or very less sodium channel blocker. Now the class 1C is the most potent sodium channel blocker in all the class 1. It will delay the rate of conduction within the cardiac myocytes. It will increase the action potential duration. It will increase the effective refractory period. It will increase the channel recovery time and the refractory periods within the cardiac impulses. The most commonly used drug is propafenone, and flecainide is also used. The dose range of propafenone is 150 to 300 milligram twice a day oral. So this was the class 1, that is the sodium and somewhat potassium channel blockers divided into subclasses 1A, 1B and 1C. The 1A are moderate sodium channel blockers, 1B are limited or very less sodium channel blockers and more specific with the membrane depolarization pathway, and the 1C are the most potent sodium channel blockers. Now moving forward with the second class, that is the beta blockers. The cardiac system is controlled through the beta adrenergic system, and more specifically the beta 1 adrenergic system. The inotropic effects, chronotropic effects, cardiac output, heart rate and stroke volume, blood pressure, everything is controlled through the beta adrenergic system of the sympathetic nervous system under the autonomic nervous system. So by blocking the beta adrenergic system, the cardiac effects will be decreased, that is inotropic effects will be decreased, chronotropic effects will be decreased, cardiac output will be decreased, the heart rate will be decreased, the force of contraction and relaxation will be decreased, and furthermore the cardiac output and even the blood pressure will be decreased. Now here comes the point of selectivity for the beta blockade. There are two types of beta blockers, that are selective and non-selective. The non-selective does not discriminate between the beta 1 and beta 2, that is it will also block the beta 2, which will result in the bronchospasm and bronchoconstriction and is never a drug of choice for the respiratory and the asthmatic patients. So even a normal patient that is taking a non-selective beta blocker will result into a respiratory disorder with the chronic use of the non-selective beta blocker. So a beta 1 selective beta blocker will be preferred, as in the metoprolol, bisoprolol. These drugs are selective for the beta 1 adrenergic system. They only block the beta 1 and do not affect the beta 2 adrenergic system. So propranolol is a non-selective drug and metoprolol is a selective drug, and these drugs will block the beta adrenergic system on the heart level. Now moving forward with the third class, which includes potassium channel blockers. Like the class 1, they are also responsible for somewhat membrane depolarization mechanisms and block the potassium channels in their open state. The effects are increase in the conduction rate of the cardiac impulses, increase in the action potential duration, increase in the effective refractory period, increase in the channel recovery of the cardiac myocyte, and decrease in the rate of depolarization of the phase 0. The most commonly used drugs of class 3 are amiodarone and dronidrone. Amiodarone is the most commonly used drug but is somewhat toxic. The second drug, that dronidrone, is the non-iodinated congener of the amiodarone and is less toxic and safe as compared to the amiodarone. The mechanism of action of both the drugs is same, that is to block the potassium channel, thereby increasing the rate of conduction within the cardiac myocyte, increasing the action potential duration, increasing the effective refractory period, and decreasing the rate of depolarization of the phase 0 impulse generation. Amiodarone is used in the dose of 400 to 600 mg per day for few weeks and is maintained to 100 to 200 mg once a day depending upon the condition and recovery of the patient. The last class is the class 4, which includes the calcium channel blockers, which includes the drugs of verapamil and diltiazem. These drugs blocks the calcium channels of the cardiac myocytes and decrease or limits the calcium channel dependent depolarization of the cardiac myocytes. When the calcium dependent depolarization of the cardiac myocytes will be decreased as a result of the blockade of the calcium channel blockers, the overall depolarization and impulse generation would be affected, resulting into bradycardia, that is decreased heart rate. Furthermore, the calcium channels are directly involved in the vascular system and are responsible for decreasing the blood pressure. So by decreasing the blood pressure, this is the second effect through which the anti-arrhythmic effects are produced through the calcium channel blockers. Furthermore, specifically the L-type calcium channels are specified for the blockade through the class 4 drugs. Re-entry mechanisms are also reduced as a result of the use of class 4, while the triggered activity of the pacemaker and the secondary pacemakers is also reduced through the use of class 4. So it is the most potent class among all of the classes because it has effect on each and every mechanism responsible for the production of arrhythmia, including the re-entry mechanisms, the automaticity, the impaired conduction, and the loss of the effective refractory period. These all things are altered by the calcium channel blockers, that is the automaticity is reduced, the conduction is also reduced to a normal level, the action potential duration is increased, the effective refractory period is increased, the depolarization, the rate of depolarization at the phase 4 and phase 0 is decreased to a normal level, and finally the re-entry mechanisms are also blocked through the use of calcium channel blockers. Verapamil is used in the dose range of 40 to 80 mg twice a day, while diltiazem is used in the dose range of 30 to 60 mg twice a day. This was all about the management of arrhythmias.